Thank you. So, Albert Einstein and Charlie Chaplin met in the 40s, and Einstein said, "What I admire most in your art is its universality. You do not say a word, and nevertheless the entire world understands you." And Chaplin answered to that, "That is true, but your glory is far bigger. The entire world admires you, although no one understands you." And I think what happens with valve disease is that there is a change in perception. No one was talking about valve disease 10 years ago, but now everybody is talking about it. And I think everybody can find reasons for that for himself. What is sure is that we know that when patients are getting older, and in particular when they're 65 years or older, the incidence of valvular heart disease is increasing. And what we also know from population-based studies is that the proportion of older patients, and in particular those over 65 years, is increasing, and we can expect a doubling of this proportion of the population within the next 20 to 30 years. And indeed, the discharge diagnosis of valvular heart disease, and this applies to aortic and also mitral disease, is in fact increasing dramatically, as you can see from these data from the National Center of Health Statistics in the US. There is a doubling between 1985 and 2005, and I think we can expect a further doubling to see here. We know more about the pathophysiology of valvular heart disease, but the challenge is that we do not have a therapeutic approach at this level yet. So what we remain to deal with are the more gross changes that appear on a phenotypical level, and in terms of treatment, it is a mechanical treatment. Obviously, we are all aware that patients who have symptomatic severe aortic stenosis, is nicely illustrated by this paper from Ross and Brownwald, have a very poor prognosis. Once the symptoms appear, the mortality is very high. Interestingly, that paper was published in the 60s, is based predominantly on a rheumatic population, which is actually not what we see currently, and it was a post-mortem analysis. So actually all these patients were already dead, and they looked back in time for how many years these patients had been symptomatic. So in a way, these findings are not surprising, but they're confirmed in more recent data analysis. Is there a risk of sudden death? That is always a concern in asymptomatic patients with severe aortic stenosis. And I've tried to summarize the studies that are available on that topic. And what you see is that on average, the incidence of sudden death is at a rate close to a rate of 0.8% per year in these asymptomatic patients. So this alone actually should not be a major reason of operating on these patients earlier. However, the question of elective surgery in asymptomatic patients with severe aortic stenosis is a question that is highly actual, in part because we have improved surgical techniques and interventional techniques with lower risks of the procedures. And here, clearly, it is an individualized decision-making process that is required, taking into consideration the risk of the intervention, potential risks associated with valve prosthesis, and also the potential risk for a reoperation. And on the other hand, we need to weigh in the potential benefits. Patients tend to report their symptoms at a late stage, and I will come on to that point later on. There's a risk of death on the waiting list. There's a higher operative mortality if patients are more symptomatic, and maybe there is a risk of myocardial damage. Obviously, we need to risk stratify the patients and individualize the decision-making process. And this is another challenge. We need criteria that are robust, and ideally, the criteria we want to rely on are simple, reproducible, with a clearly defined threshold that are validated in a large patient population, or as large as it can be in valvular heart disease. And they should also be validated against other accepted criteria. And I think this is a problem with some criteria that are put forward in the literature, that they are actually not validated in comparison to already accepted criteria. and they're not always validated in a purely population of severe stenosis. We're very lucky to have the European guidelines that have been updated last year, and we're even more lucky to be able to expect the American guidelines, which will be updated, I think, later this year. And it is always a cycle. New evidence is incorporated into the guidelines, and as soon as they're published, clinical practice engenders new evidence, and guidelines are always behind, although the cycle is increasingly accelerating. Still, in valvular heart disease, when it comes to the indications for intervention, for surgery, most of the level of evidence is a level of evidence C, based on small studies which are not randomized or consensus of experts. We only have few data that are based on the level of evidence B, which are now related to TAVI, in particular in the comparison with conventional surgery, because these were larger randomized studies published very recently. So overall, in asymptomatic patients with severe aortic stenosis, if you follow a watchful waiting approach, if you follow these patients closely, these patients will achieve a good outcome, and survival is not significantly different from that of an age and gender matched population, provided you actually follow these patients closely and you identify indications for surgery as soon as they appear. Exercise testing has been recognized, and there are several studies that have confirmed this finding, that exercise testing is safe in asymptomatic patients. And the most important finding is that 1/3 of the patients who claim to be asymptomatic actually have latent symptoms. They just do not go to their limits. They're not aware of potential symptoms. So you need to exercise these patients. And although this is state of the art, there are also some challenges to that, in particular in older patients over 70 years, where exercise-induced symptoms may not be as specific as in younger patients. We need risk stratifiers, and we have been able to identify a high-risk population in patients with severe aortic stenosis, namely those who had a calcified aortic valve, and in addition, a rapid hemodynamic progression from one exam to the next, defined as an increase in peak aortic jet velocity of more than 0.3 meters per second per year. And if patients actually present with both of these criteria, calcified valve and rapid hemodynamic progression, the 2-year event rate with a need for surgery is in the range of 80%. So you can actually consider elective surgery in these patients, but you need to be aware that the assessment of progression may be operator dependent and center dependent. So probably it is wise to document at least several exams where you document this progression in a more unequivocal way. And when we just try to look at a subpopulation of patients with very severe aortic stenosis, defined by a peak aortic jet velocity of more than 5 meters per second, and we have tried to look at potential predictors of outcome in this high-risk population, and you can see in the left panel that peak aortic jet velocity allows further risk prediction, and patients with a peak jet velocity greater than 5.5 meters per second had an even higher rate of events. However, in that range, aortic valve area was not of additional prognostic value, and this may be related to imprecisions of the assessment of aortic valve area in clinical practice. But there is now, I think, compelling evidence that peak aortic jet velocity is an important predictor of outcome across the entire spectrum of aortic stenosis, ranging from mild over moderate to severe, and even beyond that to very severe aortic stenosis. These patients have indeed a very high event rate. So if patients actually present with a very severe peak jet velocity, the expected event rate is very high, and this is a simple and unequivocal parameter that you can use in that context. And I also believe that the definition of the entity of very severe aortic stenosis makes sense, and personally I would feel that using a cutoff of 5 meters per second, which corresponds to 60 millimeters of mercury for the mean gradient, would make sense. And probably aortic valve area should not be looked at that strictly. In our series, patients who had a peak jet velocity greater than 5 meters per second had valve areas comprised between 0.3 and 0.9 centimeters squared. So 0.6 centimeters squared might not be the ideal parameter to define very severe stenosis. We always want to have more. We always want to have objective criteria to identify things that we do not see with our eyes, and clinical biomarkers are very interesting and appealing. I think what we see from these three examples, you see three studies looking at BNP values, and they all come along with different thresholds as a positivity criterion. If the BNP value is low, event-free survival is good with very low rate of events. However, the threshold is difficult to define, and I think this is why BNP is still on neutral grounds currently. Maybe BNP, the information of BNP can be integrated with valve severity, and I think this concept makes sense because the severity of valve disease, and which is reflected by peak aortic jet velocity, as taken up by this paper by Jean-Luc Monin, makes sense. And in addition, BNP may add on some information. You may have patients who have latent left ventricular dysfunction, but still there is a problem of the non-specificity of BNP. There are very interesting recent papers looking at exercise hemodynamics, exercise echocardiography in particular in patients with aortic stenosis. And this concept has been proposed by Patrizio Lancelotti, and you can see patients who had an increase of their mean transvalvular gradient of more than 18 millimeters of mercury were those more likely to suffer an event during follow-up. What we need to recognize, however, is that this study only reported 18 events, which is a rather small number of events to define and to accept this as a surgical criterion. And then there was a second follow-up study where an increase of the mean gradient during exercise was defined by more than 20 millimeters of mercury, was identified as a predictor of outcome, in addition to the value of a mean gradient at rest of 35 millimeters of mercury. But I don't think that this makes much sense, because a mean gradient of 35 millimeters of mercury is in the range of moderate aortic stenosis. So you do not need this information, and this may be actually quite misleading. And I think this is why we need to identify and describe additional predictors of outcome in nicely defined series of patients having purely severe valve disease. There are some interesting data relating to left ventricular mass. If there is appropriate hypertrophy, event rates may be higher. But again, the independent value of this factor has not been demonstrated clinically, but it is obviously an important area of research where we also see increasing levels of myocardial fibrosis in patients with aortic stenosis, but it is unclear whether we can prevent it by an earlier intervention. So if we look at the indications for surgery in asymptomatic patients in the European guidelines, I think obviously there are some related to exercise-induced changes, symptoms during the exercise test, or a blood pressure drop during the exercise test. And then there are 2A indications, namely the presence of very severe aortic stenosis or the presence of a calcified valve and rapid hemodynamic progression. And in the European guidelines, there are several 2B indications, namely markedly elevated BNP levels, an increase of the mean pressure gradient across the aortic valve during the exercise test by more than 20 millimeters of mercury, or an excessive left ventricular hypertrophy in the absence of hypertension. And these are 2B indications, but as you have shown previously, the data supporting this evidence is relatively weak, and I think I would be curious to see what the American guidelines will say regarding these criteria. At the present stage, I would be rather cautious using these and rather integrate them as additional elements in the decision-making process only. And I think, as Henri Poincaré nicely said, science is facts, just as a house is made of just as houses are made of stones, so is science made of facts, but a pile of stones is not a house, and a collection of facts is not necessarily science. And I think we clearly have to weigh the evidence that we put into our clinical practice. And when we talk about challenges, I think we need to talk about multivalvular heart disease, because we're increasingly seeing patients with multivalvular heart disease. We used to see patients with multivalvular disease in the rheumatic era, but again, with degenerative disease, these patient numbers are increasing, and the guidelines are quite honest. They say data on mixed multiple valve diseases are lacking and do not allow for evidence-based recommendations. But I think we need to gather data in this regard, because these patients are now increasingly seen. I just wanted to highlight some data on combined aortic valve disease, where we looked at 71 asymptomatic patients who had at least a combination of at least moderate aortic stenosis and moderate aortic regurgitation at the same time. These were relatively young patients with a mean age of 52 years, and nevertheless, event rate was high, and outcome after surgery was good, and aortic jet velocity, which actually reflects both the severity of aortic stenosis and of aortic regurgitation, can be used as a predictor of outcome in these patients and guide the risk zone where our patient is. And you can see that patients with higher aortic jet velocities are more likely to need surgery in the near future, but remembering that surgical outcome was good in all of these patients. Then we have the association of aortic stenosis with mitral regurgitation, which is more and more frequent in the era of TAVI, and we need to be aware that it is frequently not an organic problem, but we have calcified mitral valves where the risk of intervention would be very high. And so clearly the balance of whether we should want to intervene on the mitral valve at the same time as on the aortic valve needs to consider the etiology of mitral regurgitation, whether it is functional or organic, obviously the severity of mitral regurgitation, and the operative and interventional risk. And sometimes it may be justified to just intervene on the aortic valve because the risk of in particular when TAVI is considered, because the risk of a combined procedure may actually be very high. And there's another challenge that we are facing in the current era. We all know that the prognosis of symptomatic severe aortic stenosis is very poor, but nevertheless, patients are not operated in 30 to 50% of the cases, depending on the series that report these findings. And this happens in old patients, but also in relatively young patients. This happens in patients with severe comorbidity, but also in those with no comorbidities, and also in patients with preserved ejection fraction. So there's not a good reason put forward why patients are denied surgery, but it happens, and awareness is important. And we need to consider life expectancy when we're dealing with these patients. If we're having a 70-year-old patient, life expectancy is still very long, in the range of 15 years. And if a patient lives through these 15 years, life expectancy when he's 85 is another 6 to 7 years. So it is a good game to play. The further you get, the more you win. But age is a matter that we have probably underestimated or not looked at specifically, and I think we should look at the role of age in managing our patients in particular. And if we look at the age in the natural history studies on aortic stenosis, you will see that most of these patients were in their 60s, and only very few patients with an older age were included. So we looked at a series, and these are unpublished data, just looking at all the patients over 70 years who are asymptomatic or who claim to be asymptomatic. And one important finding is that 30% of these patients actually had an impaired mobility related to orthopedic conditions or others. So the assessment of symptoms is obviously difficult in these patients. But surprisingly, the event-free survival rate was very low. Approximately 80% of these older patients needed surgery or died within 3 years. And you can see this applies to both patients between 70 and 80 years and patients over 80 years. And there were 9 cardiac deaths, and this cardiac death rate in this older population seems to be higher than that in the younger population. And again, even in the older patients, aortic jet velocity is a predictor of outcome. If the velocity is higher, event rate is lower. We now have for the first time level of evidence B data in valvular heart disease, in aortic stenosis, when it comes to TAVI, and these are data from the partner trial. This is the comparison of TAVI versus a conventional management in inoperable patients, and you clearly see that there is a survival benefit when performing a TAVI procedure. And we also know that in high-risk patients, these are data also from the partner study, that surgery and TAVI yield a similar survival at 3 years. Nevertheless, there are predictors of outcome that we need to consider even in these patients in terms of mortality, and the France registry has nicely shown that if patients are more symptomatic at the moment of intervention, long-term survival will be worse. And even more importantly, there is an increased mortality related to cardiovascular disease, but also to non-cardiac causes. And approximately half of the patients after TAVI currently die for non-cardiac reasons. And this is also highlighted by the source registry, where you can see that 50% of the mortality after TAVI is non-cardiac, related to pulmonary disease, renal failure, cancer, or others. And I think in the current era, it will be more and more important to be able to identify these patients in order to allocate the treatments in the right way. And obviously, we have had a tremendous advance with new valves, and you can see here examples of the SAPIEN valve, the core valve, and the Engager valve, which are currently on the market, but there are other valves pushing into the market, and it will be challenging to assess newer valves, changes in design in an appropriate way. I think we never had an evolution cycle that was as rapid, which is obviously positive for the patient, but at the same time, it poses risks, and we clearly need to think of how we want to evaluate this incremental knowledge and the potential advances in technology, which may not always bring a benefit to the patient. There will obviously be some iterations in design that will be harmful, but we need to be aware of that and think about this when looking at the future. Obviously, management of patients with valvular heart disease has become more complex, and in terms of the timing and the type of intervention, several factors need to be considered now. We need to consider the life expectancy of the patient. We need to individualize the risk of an intervention, and also the risk of the natural history and its evolution. We need to consider patient preferences and weigh the risk of interventions, the potential need for reinterventions, and the long-term post-procedural outcome, and all that in a team approach. And I think the team approach has become a reality in the management of patients with aortic valve disease and with valvular heart disease in general, and there is closer and closer collaboration between different specialties, and in particular between cardiac surgery and cardiology, and I think this trend will only continue. But this is not everything. We need to reach out further, because these are patients that are already addressed, but patients are addressed at a very late stage. These are patients, 422 patients from that study that were already addressed to valvular heart surgery, to aortic valve replacement, and 48% of these were New York Heart Association class 3 and 4, and mean time from referral to actual aortic valve replacement in that study was another 112 days. So what we know is that patients are being referred late when they're already symptomatic. On the other hand, we have now the concept of heart valve clinics, and where we can actually follow patients as long as they're asymptomatic in a close fashion, and then decide on the ideal management. And these are data from our experience, where you can see that patients who are referred to when they're initially who are symptomatic at their initial presentation had been symptomatic for an average of 350 days. So patients are actually really referred at a late stage. However, if they were referred for the first time, as long as they're asymptomatic, and we could enroll them in a follow-up program, we could identify the onset of symptoms with a delay of only 90 days. But interestingly, even in patients that are followed closely with 6 monthly follow-up exams who are instructed to report symptoms promptly, we see that only 20% will report the symptoms before the next scheduled visit, whereas 80% will wait for the next visit to report their symptoms. So actually, patients are not as independent as we would like them to be, and we need to follow these patients closely. This is also reflected in the degree of symptoms. Patients were symptoms at their first visit, as you can see on the left panel, had severe symptoms in the majority of cases. 60% of these patients presented in a New York Heart Association class greater than 2. However, when they're followed in a close follow-up program in a valve clinic, 70% can be referred to surgery or intervention in the New York Heart Association class 2. So the concept of the heart valve clinic, I think, is important, and we have recently published a position paper on that topic. We're actually reaching out to the community is important. Patients can be addressed to heart valve clinics, which can be either constituted as standard heart valve clinics, where there is a profound knowledge of imaging and management of valve diseases, or an advanced heart valve clinic, where in addition there is interventional cardiology and cardiac surgery present on site. And obviously, the heart valve clinic is complementary to the heart team, which actually is related more around the concept of multidisciplinary decision making. But what the heart valve clinic allows is to actually manage these patients in an appropriate way, inform the patient, schedule exams, take appointments, and deliver appropriate care, and follow these patients in time. And the advantages of a heart valve clinic can be seen at different levels. There's optimized patient management. There is a role for education and formation, because if in a heart valve clinic you see large numbers of patients, education and formation will be more effective. And this also permits to establish research programs in a structured way. And ultimately, a heart valve clinic can have effects at several levels in the healthcare environment. It can have a direct effect related to the improved outcome of these patients, regional effects, because the center will be recognized as a center of excellence with a positive synergy for interventional and surgical programs, and ultimately it may affect the whole healthcare environment on a global basis. So to summarize, I think we actually have advanced our knowledge in valvular heart disease dramatically over the last years, but challenges remain open. We were able to refine surgical criteria, but still further risk stratification elements are required. Guidelines are still mostly based on the level of evidence C. We now have improved surgical techniques and catheter interventional techniques. Unfortunately, no established therapies at the pathophysiological level. We see increasing patient numbers that we'll need to be able to take care of, with more challenging decision-making process in multivalvular disease, with specific patient subgroups such as the elderly, high-risk patients, where also the futility of valve intervention needs to be considered. But all that, I think, has brought us to think of treating these patients in a team approach, and also realizing that we need dedicated heart valve clinics. I thank you for your attention.
Thank you very much. We have time constraint, but there's one question from.
Good LP.
Yes, obviously this is another challenging area. For the sake of time, I didn't touch on this. It is a reality. So paradoxical low flow, low gradient aortic stenosis, despite preserved ejection fraction, is a reality. It is probably has an incidence that is probably lower than that was first reported in the first series. We have to clearly rule out that there is underestimation of true severity, which is frequently the case in this situation. So trying to measure the peak aortic gradients from alternative imaging windows. And then the decision making is very difficult because there may also be an overlap with a left ventricular problematics such as heart failure with preserved ejection fraction. So maybe these two diseases coexist. In terms of decision making, looking at the extent of valve calcification may be helpful to decide whether we believe that this is indeed true severe aortic stenosis. And then decision making needs to be individualized, and in selected patients, actually intervention is indicated.
Thank you very much. I thank Professor Rosenhek. I thank the